Welcome to the ASRS Oral History of Retina series. The purpose of these interviews is to capture first-hand stories from individuals with unique retinal insights of historical significance.
Through these discussions, we will fill in gaps in our understanding of the evolution of the science and practice of retina. And it's our hope that these discussions will serve as the illuminating element in the larger mosaic of the history of retina.
It's such a pleasure to have as my guest today Dr. Michael Trese. Dr. Trese is a partner and past president of Associated Retinal Consultants in Royal Oak, Michigan, professor of ophthalmology at Oakland University, William Beaumont School of Medicine, and he's founder and chairman of the Pediatric Retinal Research Foundation. Over his 38-year career, he has published over 300 peer-reviewed scientific papers and 33 books and book chapters. He has served on 7 scientific journal editorial boards and delivered well over 1,000 scientific presentations and courses in numerous countries across the globe. Dr. Trese has served as president of the Retina Society, co-chair of the ARVO Program Committee, chairman of the AAO Retina Subspecialty Day, and chairman of the AAO Telemedicine Task Force. He served on the executive committee of the Cryo-ROP study. He was a member of the International Committee for the Classification of the Late Stages of Retinopathy of Prematurity. He's received so many major awards and given so many named lectures that naming them all would consume all the time we have for our discussion today. So I'll simply refer you to his CV for that information. Mike, thank you so much for joining me today.
John, it's a pleasure to be with you. I've been looking forward to it.
You started your education at the University of Michigan, graduating in 1968. That was followed by attendance at the Pennsylvania College of Optometry. What kind of gave you exposure to medicine that led to your thought that maybe that was a career for you?
Well, actually, I liked biology, and I liked science, I liked math. And my father had a friend who was Undersecretary of Health, Education, and Welfare. And my dad explained that to him, and he said, well, you should go to optometry school. At that point in my life, I'd never had an eye exam. And I had got a job from the football team working as a scrub nurse in the operating room at St. Joe's Hospital. So I'd seen ophthalmologists, and in fact went to optometry school thinking that that's what I was going to be, and was a little bit surprised when the second day they explained the difference between optometrists, ophthalmologists, and opticians. So that was a wide awakening. But yeah, it was mostly that exposure as the scrub nurse, and then my father's friend advice that put me in that direction.
So you went to optometry school where you realized optometry and ophthalmology were not the same careers.
Right.
And at some point you made the decision, I actually really want to be an ophthalmologist, so you then went to medical school?
So I was advised to finish optometry school and then apply to medical school. That's what I ended up doing. And actually, I know you won't believe this, and I know the younger doctors yet won't believe it, but I was able to pay for my medical school by working the summers, the little time I had off in ophthalmologist offices, because the tuition was so much less. And it used to be that Yale and Georgetown were the 2 most expensive medical schools in the country, and but it was much, much less than what it is now.
Yeah, I remember the tuition of Georgetown. You're right. It was painful.
Yeah.
So you graduated Georgetown in 1976, but during your stay at Georgetown, you had some really incredible experiences. You spent time with Dr. David Kogan at the National Eye Institute. This is a guy known as a neuro-ophthalmologist, but really he was world famous for ocular pathology and his research in cornea and retina. How did you end up working with someone like that, and did you recognize the stature of that man?
That's a great question, John, because I didn't. And the way I found out about him, one of my best friends in medical school His dad was chief of surgery at Georgetown, Dr. Coffey. And he had a dinner party at his home, which I was invited to. And this guy came up to me and said, I've just gotten out to NIH, and I understand there's a pretty good ophthalmologist out there now. You might want to take a rotation with him. So I signed up. It was David Kogan. And I had like a 3-week elective that I could use during my junior year. And so I went out and I met David, and he said sure for the elective. And I came, and we didn't really have PubMed or anything then. So I researched him as much as I could, and I discovered that he'd actually written 5 papers. a little incomplete search, but I thought that was fine. It was more than I'd written at that time, so I thought that was pretty good. So then I went out, and Bob Yee was his fellow, who ended up being chairman of ophthalmology at Indiana. And as I finished my 3 weeks, David said to me, you should really spend 6 months out there your senior year. You really should. And I said, no, I can't do that. They'll never, ever let me do that. He said, talk to your dean. So I spoke to Dean Rose, who I owe a great deal to. And I said that, I have this opportunity to do this with David Kogan for 6 months at NIH, and Dean Rose let me do it. I had done very well my 3rd year, and my statement to get into medical school, my first sentence was, I want to be an ophthalmologist, and I understand I have to go to medical school to do that. And so it kind of framed my whole medical school experience. And then, after I did the 6 months, David said to me at the end of 6 months, he said, Mike, you really should spend 6 months with Zim. And because every Wednesday we had been going to the AFIP meetings, and I said, there's no way. I've already missed half of my senior year of medical school. There's no way. So I went to Dean Rose and I said, actually, the next time I'm going to be in a CCU is as a patient. I'm going into ophthalmology. And he let me do 6 months with Zimmerman and Ray Font. And it was wonderful. The whole year was fantastic. And I had formed the opinion that all ophthalmologists were like that, like David Kogan and Lorenz Zimmerman. That isn't true. You may have noticed that, John, but it is not really true. But they were both fantastic teachers and inspirational. I actually was going to go back and be David's fellow and go into neuro-ophthalmology. But then I had to call him and tell him I was going into retina, and he was rather thrilled that I was going to be with Robert Mockemer as opposed to Charles Scapins, they were not really great friends. But yeah, it was an interesting period.
Well, that's an incredible senior year for medical school with these two gentlemen. And, a lot of people, in this day and age, they're not even familiar with Lorenz Zimmerman, but this is a kind of a world-class guy that really created ocular pathology. The AFIP is the Air Force, the Armed Forces Institute of Pathology. And back in the 30s and 40s, and this, but I'm saying this for the people that are watching, in the 30s and 40s, the very prestigious ophthalmologists dabbled in eye pathology, but it was really Lorenz Zimmerman that created this academic framework around ocular pathology and actually created the subspecialty of eye pathology. And he was responsible for that. And he was world known for being inspirational and for training the world's best ocular pathologists. And so he was very highly sought after. So what a prize to be able to spend time with both of those gentlemen in your senior year. That's remarkable.
Yeah, it was a wonderful, wonderful experience.
So from there, you went to the West Coast. You did your ophthalmology residency at Jules Stein Eye Institute at UCLA. And so was this when you got your first exposure to pediatric retina?
No, actually I got my first exposure to retina really at UCLA with Buzz Krieger and the rest of the retina service there, and found out that it was just fascinating. I really loved it. And I remember back then our weapons were much less. The buckle was our best friend, And vitreous hemorrhage was vitrectomy. I mean, that was pretty much what it was. And with a lot of elevated intraocular pressures post-surgery. I remember making rounds after inpatient vitrectomy surgeries, and if the pressure was 70 or less, I thought that was pretty good for the first day. And nobody did membrane peeling. My first pediatric exposure was at Duke as a fellow, and Robert and I did a ROP case. He did the case, I watched the case. And during the case, we made 5 observations that we thought were new, independent information. And right afterwards, I went to the library and looked up Terry's paper from the 1950s, which was histology on retrolental fibroplasia. And everything we thought was brand new, Terry had described in that paper, every single one of them. And that was my first exposure to pediatric retina.
So was there any experience that you had that really triggered your interest in ROP, where there was an incident case where people threw up their hands and said nothing can be done, and that motivated you, or was it something else?
As a resident at UCLA, it used to be that the second-year resident would do ROP rounds, RLF rounds, not knowing much of anything about what we were looking at. And so I saw a child there, and I said, well, why don't you come back in a month? Because there was no real scheduling regulation or understanding of how the disease progressed. And they came back in a month, and they had bilateral retinal detachments, white retrolental membranes. And I ran to go get Krieger, who came back and told them there was nothing that could be done. The child was going to be blind. And that really got me very interested in ROP. It was difficult to just find who was more disturbed, the mother or me. And then I found later on that many people that were involved in ROP, specifically John Flynn, who unfortunately just passed away a little bit ago, had a similar experience, not so much a patient experience like that, but was at a deposition and realized that the attorney knew more about then retrolental fibroplasia than he did, and vowed that would never happen again, and it didn't. John had a few flaws, such that he went to Notre Dame, but other than that, he was a pretty decent guy. But yeah, that was a very moving, pivotal experience in terms of ROP. And then the next real surgical experience was the one with Robert at Duke, and the only one like that while I was a fellow.
So you were trained by many very impressive people. Is there anybody in particular that stands out as someone that was very impactful or influential in your career?
I frankly have often blamed David Kogan for me not having enough downtime. And you know, it's amazing the number of people that he inspired. Mockemer was the same way. One person that doesn't get mentioned very often was Bob Foose, who worked at UCLA, was an ocular pathologist. I mean, all of them were just wonderful. But David really instilled in you a desire to make a contribution to the profession. And I think that motivation is something that is behind so many people. And if you talk to people that have spent time with David, there are just so many that are nourished by that thought. And I think that it's a wonderful thought. It's something that is more valuable than money. It's more valuable than any things. It's really the concept. And I think that's also what makes good teachers, is the concept of trying to make a contribution to the future in the terms of people that you share your thinking with. So that I think is very, very, and David was just a wonderful man, wonderful person.
And so you had an early interest in pediatric retina because of your experiences, both at Jules Stein and with Bob Mockemer doing that ROP baby. When you went into practice, that must have been sort of daunting, though. Now you're on your own. What was your experience when you encountered that first stage 5 ROP detachment? Did you just dive in head first? Did you call Bob and say, hey, maybe give me a helping hand here? How did you address those issues?
I called Robert and I said, I think I should send this patient to you. And Robert said to me, well, let's talk about this for a minute. I said, okay. Said, how many patients have you been involved in? To me. I said, well, that one that we did, remember when I was a fellow? He said, oh, yeah, I remember that. He said, how many patients have I been involved in? I said, I really don't know how many patients you've been involved in. He said, 2. So your experience is half of mine. You keep them. That's exactly what he said to me. And so I did. And we did what we thought was reasonable, not really having complete understanding about the shape of the retinal detachment or how the disease progressed. I mean, we didn't even know what VEGF was back then, and it was a very challenging case. There was a hospital on the western side of the state, which still has the largest NICU in the state, and over a period of a year, they had 20 bilateral stage 5 eyes, 20. And so that year, I did like 40 stage 5 ROP eyes and was developing some understanding of a technique that was an approach that could lead to some function. I went to the first Vail meeting that I was ever invited to, and in those days, the Vail meeting was like 60 or 70 people from all over the world. Robert would invite them, and they would be told at the end of the Vail meeting, if you're not doing something new, you won't be invited back. And we had no industry there. Robert would tell industry, we need $50,000, $20,000, and by the way, you can't come. And he could get away with that. You know, it's kind of hard to do that these days. But I was at this first Vail meeting, and they started to talk about surgery for ROP, and I was sitting next to Mort Cox. And I turned to Mort and I said, yeah, that's not right what they just said. And he said, well, stand up and tell them that. I said, I can't do that. These people are all, you know, my heroes, the ones that, and Mort encouraged me to do it, and I did it. I stood up and I said it, and I heard from behind me George Blankenship go, who was that? And then from that point on, I ended up seeing a lot of ROP detachment cases. So it was an interesting bend there also.
You have a lot of patents and pending patents. You have 9 patents, I think, and several others pending. And some of your most popular tools I used when I first started in practice, when we were using larger gauge instrumentation, your dissecting spatula, your lighted pick, the membrane peeling scissors. These are things that really enabled retina specialists across the globe to do better work. Where did you have the wherewithal to do that? Was that all done mainly when you were, at Duke, or did it follow that, and were you able to connect with industry and work on these instruments when you were in practice?
It started at Duke, surely. I mean, you saw a problem, you figured out how to try and fix it. The industry agreements were something that are a little more difficult to understand and appreciate, usually based on royalties or something like that. I remember once walking the floor with Mockimer trying to make some real important point to him, but he was very distracted. And finally I said to him, "What are you doing?" He said, "I'm looking for patent violations." The industry is very approachable on new instrument design and stuff because, if they can come up with an instrument that is valuable, they do very well with that. Alcon still now is becoming back again an instrument company. So and I think that the surgeon that's approaching a problem knows what the problem is. And then if they can come up with a way to creatively deal with it, that's fantastic for everybody.
So you deal with an incredibly difficult population, right? These are very young patients that have blinding diseases. The parents are anxious, they're stressed out, they're very concerned. What advice do you have to new emerging pediatric retina specialists on what characteristics, personality traits, skill sets that they need to develop to make them at the top of their game in this industry?
Well, it is a challenging population to work with from that standpoint. I think that you have to be completely honest. You have to outline all the possible downside. You have to manage expectation because success may be ambulatory vision, which is not what a cataract surgeon thinks of success, and not what parents often think of success. When they talk about seeing, they're talking about seeing the way they see, which may be 20/20 in each eye. And the likelihood that you can achieve that in some diseases is very, very low. So I think that you have to develop an honest, straightforward relationship, explain to people exactly what they are. Originally I found it very difficult to be able to say to people, your child's not going to have great vision. They may have some vision, but it's not going to be the vision you and I would both want for them. And I think that if they understand that we're all on the same page, we're all on the same team, we're trying to do the very best thing for the child, and sometimes the best thing is to do nothing. Sometimes the best thing is to do a surgery or a technique that has a lower success rate, but has a success rate. And so it is difficult, and it requires a person that's able to deal with failure, because most ophthalmologists, I think, are very success-oriented. They've done very well to get an ophthalmology residency. They've done very well to get a retina fellowship. They now want to see success, and they love puckers, they love macular holes, and those are very high success cases. But you can really change a child's entire life doing pediatric retinal procedures, but you have to understand the diseases. It gets back to ocular pathology. If you understand the disease and the disease course, you can tune intervention to it. And that's kind of what I like most about it, is that you can take a very difficult problem and kind of work through it piece by piece. But it does require tempering the patient, not the patient so much is the easiest part, but the parents are a difficult part. And sometimes the doctors have a misunderstanding of what the goals might be and what's achievable and what isn't. But yeah, it is a challenging group.
And how satisfying it must be, though, over the course of your 38-year career and counting, you must have so many patients that you treated as infants that are now adults with kids of their own that are able to function visually because of the work that you've done.
Yeah, that is very rewarding, John. I have every week, I see people come in that have 20/30, 20/40, 20/20 vision that in many years ago would have been blind. The actual rate of blindness now from ROP is 90% success with laser, and then you can talk about anti-VEGF as well, but that's a whole nother discussion. And then 90% success with lens-sparing vitrectomy, which leaves you at about 1 or 2% of children that are blind. And when I started doing it, that was closer to 50% when they got detachments. So it's a very, very rewarding thing. And a lot of the patients appreciate it. Every week I have someone that says, "I thank you for my vision," and it's a great feeling.
You're obviously such a curious person. You're so bright. You've got over 300 peer-reviewed publications, and it spans, both pediatric retina and adult retina, which is so remarkable. If you had to pick what you think is the most important paper or research that you did in pediatric retina, what would that be?
Well, I think that the thing that I think made the biggest impact was lens-sparing vitrectomy and ROP for 4A ROP detachments. And that story is somewhat interesting in that when I was an intern, and I interned at Beaumont Hospital, there was a woman who came in, African-American woman, who got in an argument with another African-American woman who pulled her afro comb, which you remember have very long blades on them, those prongs on them, and had gone to stab her with it, and it had gone through the pars ciliaris superiorly and out the pars ciliaris inferiorly. So at that time, residents and fellows were taught that if you entered through the pars ciliaris into the eye, that there'd be terrible amounts of bleeding, and it just should be avoided. So I recalled that what we did very carefully with that woman was to pull it out of her eye, and she didn't bleed at all. She got a couple of sutures in the larger puncture wounds, and her lens was clear, and she came to 20/20. So that was my internship. So I recalled that case, and I think almost all of us would because it was a tad unusual. But it did show me that maybe it wasn't right about the pars ciliaris being this thing that had to be avoided. And remember, premature children are born without a pars plana. They have a pars ciliaris, the oris aurata, and retina starts. So we at that time were still doing buckles for these 4A detachments, which were not doing well. And we felt the only way we could enter the eye was by removing the lens and getting in the eye that way. And so we were learning that 4A detachments, if you were there at 38 to 40 weeks, the chance of them progressing to 5 was extremely high, in the 90% range. And so that we were looking for a way to try and stop that, and vitrectomy seemed to be the way. But then if you made them aphakic, then you had all the issues of refraction and aphakia. So we decided to try and do a pars plicata, pars ciliaris vitrectomy, and lens-sparing vitrectomy. And I remember like it was yesterday. Al McGuire was with me, and we didn't know what was going to happen, but we entered the eye through that path. We didn't have any bleeding. We did the other instrument. We do a 2-port instrument in children, then still do. And it was a tremendous success. And we started then to get visions, phakic visions, that were as good as 20/20 with these 4A detachments followed now for many years. So I think that is what I think is the most pivotal paper. There are other papers that were, I think, good from a science standpoint, histology, ocular pathology standpoint. But I think that one made the most clinical difference because it was something a lot of people have now learned how to do, and undoubtedly has saved a lot of vision for children all over the world.
That's such an incredible story, and it's so typical of a brilliant innovator like yourself to be able to reach back, no, really, to other experiences that seem unrelated and make the connection. So now from this very unusual case of trauma, you had this fundamental rationale for why there may not be bleeding. And it takes people like you, obviously, to act on that and to do that first gut-wrenching case where you're not really sure what's going to happen.
There were a lot more of those cases in the past. Almost every case was like that, you know. But now, as we learn more and more, sometimes we try more and more, or sometimes we're comfortable now approaching things that in the past would have been very disconcerting.
Well, Mike, you must feel very satisfied as you reflect on your career, which is ongoing, but so far your 38-year career, if my counting is correct, just so spectacular, spearheading pediatric retina and adult, surgical retina. People admire you, they respect you, they love you. I'm so appreciative for you taking the time today to chat. It's been such a pleasure. Thank you.
Well, John, thank you very much. Those are very kind comments, and I consider it going both ways. The patients have been allowing us to take care of them and to do some very significant surgeries on them, and we've been motivated by trying to make a contribution to the profession and to our patients.